Hello, and thank you for joining the American Academy of Pediatrics webinar, COVID-19 Pandemic, Clinical Guidance for Pediatric Practices. My name is Dr. Chris Nyquist. I serve as Professor of Pediatric Infectious Disease and Medical Director for Infection Prevention and Control at the Children's Hospital, Colorado. And I'm a member of the American Academy of Pediatrics Committee on Infectious Diseases, and I serve as the lead for Emerging Infections and Outbreaks Subcommittee. The outline of our discussion today starts with what is a coronavirus, where did it come from, what is the current worldwide epidemiology of COVID-19, what is the treatment, and most importantly for our pediatric colleagues around the nation, what can I do? For a disclaimer, much of the information you will hear will be out of date within hours to days, and many of you know this is a rapidly fluid moving situation, and it's important to search the best source of information for your area. The best websites I feel for up-to-date information include the CDC, the World Health Organization, and truly your public health department, so your local or your state public health department, as they will have the local epidemiology and what your current local status is. And those websites are listed below on this slide. My disclosures, I serve as a member of a data safety monitoring board for Pfizer, and during this webinar, I will mention one experimental drug. So let's start talking about coronaviruses. So the name coronaviruses goes back to what the virus looks like as an electron micrograph. And if you look at the upper corner of the electron micrograph, the spokes look like a crown, so therefore coronavirus. Now, there are 7 human coronaviruses that have been identified, and we have HKU1, NL63, 229E, OC43. And one of the important things to note is these are viruses that have been able to be identified in normal routine respiratory viral panels that many of you may do in your offices or in your hospitals. So these common coronaviruses are in worldwide circulation. They primarily cause the common cold that may be more severe in neonates. These coronaviruses are often more common in children than adults, and they do have a seasonality during the winter and early spring. We seem to have outbreaks every 2 to 4 years. One of the common questions I've had when a pediatrician receives a test result, they've seen positive for coronavirus. And this is a different coronavirus than what we're talking about now with this novel coronavirus. And our routine respiratory viral panel testing cannot identify the COVID-19 SARS-CoV-2. Bats are a natural reservoir for many viruses, and for coronaviruses, this is also true. We've seen novel species of coronavirus arise from when there's a combination of a bat virus and viruses of other mammals. In our past history, we have seen SARS, or severe acute respiratory syndrome. We've had Middle East respiratory syndrome, or MERS. And then now we're talking about coronavirus 2019, or COVID-19, which is the disease, and the virus, which is called SARS-CoV-2. The novel strain for COVID-19, or SARS-CoV-2, is thought to be a combination between bats and the pangolin. It started initially, it was identified in Wuhan City in Hubei province in China, and that was around the end of November, beginning of December of 2019. And at this point, with the asterisk, we have 155 countries and regions who've reported cases, and this is defined as a pandemic, a global pandemic. The World Health Organization declared an emergency at the end of January. The U.S. a day later, declared an emergency. And then on March 11th, the World Health Organization declared that COVID-19 was a pandemic. This picture shows you what the current, as of today, March 17th, 2020, what countries and regions have COVID-19 identified by microbiologic testing. One of the things that's very important to note is that many places do not have the ability to do testing if they are lower income, lower resource countries. And so the grayed areas where you do not see COVID-19 identified, we anticipate and we believe that there is virus spread there, but we just haven't been able to identify it yet. When we take a better look at what's from the World Health Organization, where more of the cases are. And so the green or the red circles show where the high areas of cases are. And so you can see that in China, that's an area with a larger red circle. And now at this point, we actually are having more cases arising outside of China than we are inside China. And the World Health Organization is a great place to see what is circulating, in particular when you think of people who may have traveled recently internationally. We'll give you an idea of what's circulating in the areas where your patients and families have come from. So COVID-19 is a rapidly evolving pandemic, and in general, 80% of illness is felt to be very mild, 14% severe, and 5% critical. Most of this data comes from a JAMA publication in February 2020 that was based on data that was reported from China. Most infected people remain well, and only 2% of the cases in this report were in children, and we're continuing to see in the United States epidemic and pandemic that most of the cases are adults and very few are identified in children. The symptoms of COVID-19 include fever or cough or sore throat or shortness of breath. The illness is more severe in those with chronic diseases as well as the elderly. The overall case fatality rate from this publication is a little difficult to determine because it's difficult to know what the denominator of all the cases are. And people were not all tested in this publication in the cases in China. And so the range really ranges from 8% case fatality rate for older people to 14.8% over 80, but it's unclear what the ultimate case fatality rate is. But we do know that chronic diseases and elderly portend a higher case fatality rate. What we have in the United States as of March 16th is a total of 3,487 cases. 68 deaths have been recorded, and we have over 53 jurisdictions reporting cases. A large proportion had been travel related, but now we are seeing more that are community associated, and that's really where the spread is coming from the local community transmission. We know that this virus efficiently spreads from person to person. For the pediatric community, we're just finishing up slowly our respiratory season, and so we're finishing up respiratory season, and now we also have COVID-19 circulating through the broader community. So a virus that spreads from person to person, thinking back to all of the training and things that you do during respiratory season are things that you need to bring upon and do during this current pandemic. We think about that the droplets from COVID-19 patients spread from 3 to 6 feet. So that means that the use of social distancing and staying 6 feet away is a benefit. We have a lot of unknowns. We don't know if asymptomatic patients are contagious. We also don't have a good idea of how long people are contagious. And the role of children is unknown, and we have limited information about what children are in this pandemic. The transmissibility of this virus, we have data from China determining that the incubation period from the time that you are exposed to the time that you get sick is anywhere from 2 to 14 days. There are some isolated reports of transmission from 19 to 24 days, but that has to be in the caveat of large community transmission, and so it's difficult to determine exactly how long the incubation period may be. The median is thought to be approximately 4 to 5 days after exposure that you will become ill. Now, the basic reproductive number is actually an important epi number that's helpful for us to understand what is the level of contagiousness of this virus. So the R0, so the R with the 0, lower 0, is how many secondary cases are infected on average by a person who is infected. And the R0 estimate is really from 2 to 5, with the idea that it's much more close to 2. We do know that this virus so far is more easily transmissible than SARS-CoV that we had in the 2000s for that small epidemic. This picture gives you an idea of well-known viruses by their R0 value. And to the far right, we have measles. And so measles R0 is 12 to 18. So many more times contagious than we have for COVID-19. And so the R0 of 12 to 18 means that if you have a person who's infected with measles, you may have 12 to 18 other people infected by that virus being exposed to a person. We have Ebola on the far left, and so that's a very limited R0, so 1.5 to 2. Pandemic influenza, about 2. You can see the lining of all of these well-known viruses by their R0 value, and we think that COVID-19 or SARS-CoV-2 is approximately 2 to 3 for its R0. This is a clinical presentation in one of the initial articles published in JAMA, and this was from China, and it looked at over 1,000 people who had COVID-19. The very few of these patients were pediatric patients, and most of these were adults. But the important things to note are that fever was a high percentage component, and cough was also a high percentage for people who had COVID-19. Fatigue was one of the other things that was noted, some myalgias, and you see sore throat and nasal congestion decreasing in percentage. If we look at the pyramid of COVID-19 illness and starting from the bottom, moving up, we note that asymptomatic and mild cases may be from 70 to 80% of those infected with COVID-19. Some people will be hospitalized, some will go to the ICU, and some will die. The majority of the deaths and hospitalizations are in people who are over 60 years of age and those with underlying medical conditions. And so far, that seems to be what we're seeing in the pandemic within the United States so far. For pediatric cases, we truly have very little information that has been published about pediatric cases. There's probably about 5 to 6 published articles, maybe 10, that we can get information from. We have very few pediatric cases compared to the adults, and it's unclear whether or not this is related to a child's physiology and how they respond to exposure to this virus, or whether they're not exposed as frequently. We also can look back at our past history with patients with MERS and SARS, and there were also few pediatric cases with those other novel coronaviruses. To date in the US, as far as we know within China, there have been no reported pediatric deaths. The pediatric clinical presentations have ranged from asymptomatic to mild URI symptoms to pneumonia to hospitalization, and with only a few hundred of cases that we can actually look to see what that looks like in pediatrics. We also have some case reports from Singapore and other locations that children who've had symptoms as well as with no symptoms have been found to have high viral loads. The diagnosis of COVID-19 is with PCR testing, and this is important for you to access to determine what your ability to do testing is within your local community. It should be coordinated with the local or state public health department, and that's why it's important to reach out to those local contacts. It's commercially available. Tests have been developed and are available in some of the East Coast academic centers, LabCorp, Quest, some other academic centers have the tests available. The turnaround time for the test is very variable, and it's difficult to occasionally find the tests. And one of the most important things in a pediatric practice is the ability to actually obtain the test requires ensuring that the healthcare worker who's obtaining the test has the appropriate personal protective equipment to get the test. This is the reason that many places have tried to develop testing centers as well as drive-through testing ability. And I would ask you to reach out to and find out from your local region or your state public health department, what is the availability for testing? But one of the big questions is who really needs to be tested? And this is where clinicians really should use their judgment to test, and what is a priority for testing? Within our institution at Children's Hospital Colorado, we are testing patients who are hospitalized with severe respiratory disease or getting hospitalized for any respiratory disease to help us with understanding what kind of PPE we need to use. Hospitalized patients may be important to test. The people who are patients who are in the ambulatory setting are well with a limited resource of testing. Knowing the answer of whether or not they have COVID-19 or not may not be as valuable. We think that older adults and those with chronic conditions or immune-compromised people, in particular, we might consider children who have leukemia or other immune-compromising conditions. That may be important to know whether or not they are infected with COVID-19 if they have symptoms. Healthcare personnel really are a special criteria for consideration of testing, because this is a workforce that we need to have taking care of our patients and our families. And so the consideration of healthcare testing for healthcare workers should be done in consideration with your local and state health departments. Treatment, there is no vaccine. There is no official treatment that has been approved. The treatment is mainly supportive. Mild cases in general do not require hospitalization. The cases that may get hospitalized are more likely to be older people or immune-compromised people. All cases require isolation. And so for those who are at home, that may mean decreasing their contact with other people for a prolonged time period, because we do not know how long a patient is contagious, and the time frame for maintaining isolation or self-quarantine changes day by day. There are drug trials in progress, and one of the drugs that is a new antiviral that is in trials in adult populations is called remdesivir, and there also are other antivirals being tested. But basically, it is supportive treatment and isolation to keep others from becoming infected. Prevention is important. Vaccines are in development, and anticipated vaccines, we hope they can come here as soon as possible, but the highest likelihood is that it will be toward the end of the year or the beginning of 2021. Patients with COVID-19 should seek care and follow isolation procedures, but this is one where it's really important to utilize telephonic methods or calling nurse call lines or talking to providers instead of seeking care by presenting yourself to an emergency room or urgent care unless you are in need of emergency care. There have been quarantines imposed for people who have had international travel, and the CDC website is the best place to look for that. And that self-imposed quarantine is for 14 days after international travel, and that changes on a regular basis, and so going to that website is important. But the basics are really the things that your mom told you to do all of the time. Wash your hands, soap and water is great, alcohol-based sanitizer when you don't have that. Cough hygiene, cover your cough, don't cover it with your hands, cough into tissues, throw those away. Stay home when you are ill, stay 6 feet for others, and utilize social distancing. All of those things are important things to prevent the spread of COVID-19 from person to person. Infection control during the time of this pandemic is really important. Many of the things that you do daily during a respiratory season in your offices is exactly what you need to do now and at an increased level. Staff education is important for them to understand what should we do when we have someone coming in with a fever or a cough. How do we identify potential cases before they come to our office? How do we utilize what personal protective equipment we have in our offices? What are the signs and symptoms of disease? Fever, cough, shortness of breath. Calls from patients are important, and talking to people on the telephone is very important. Will help you to triage and assess who should be evaluated for further care. For patients who come to your office, the ideal would be to put them into a closed room. It does not have to be a negative pressure room, because we know that in clinic offices, you often don't have a negative pressure room. And then put them in the room and then really decide what are the next steps for those patients. But the ideal would be for them not to come to the office if they're not sick enough to be seen. Many offices had very innovative and creative ways to work with their practices. Some offices who have 2 offices, one is designated as those for sick kids, another for well child care. Some offices have had mornings where they have the sick kids seen, or the well kids in the morning, sick kids in the afternoon. One of the most important things that everyone in the office can do is wipe down surfaces, every pen, keep on cleaning. Within many hospital settings, elective surgeries are canceled, and that was a recent recommendation from the Surgeon General, and that may be a challenge for many people. Encouraging sick staff to stay at home. It still is not too late to get your influenza vaccination, since we are still seeing circulation of influenza in the community. And really having that relationship with the local and state public health departments is important to find out what is circulating and happening in your local community. When to use personal protective equipment really is that decision when you think someone has an illness that they're going to transmit to you in the way that they're going to transmit. So for example, if you're drawing blood, we wear gloves when we draw blood because of our need for personal protective equipment and using gloves to prevent bloodborne pathogen exposure. If someone is coughing, putting a mask on that person will help to keep their cough from spreading throughout the environment. And you can wear a mask, a regular isolation mask, as well as if you have the ability to have goggles or eyeglasses to help keep things from your eyes. The differences in PPE really depend upon what your risk of exposure is. We know that if you are doing an aerosolizing procedure, such as obtaining a respiratory specimen or intubating a patient or doing bronchoscopy, those are high-risk exposures. And so that's where in the hospital setting, it's easier for us to utilize respirators such as PAPers or N95s in addition to face masks. The key thing is that even in the office practice, the simple act of washing your hands, wearing a mask, having people wear a mask when they're coughing, having eye protection when people are coughing are really important for preventing infection spread from everything from influenza to novel coronavirus COVID-19. Cleaning your practice is very important, and routine cleaning disinfection procedures are key. And any of the EPA-approved products which are on this list are effective. You do not necessarily need to use bleach products, any of the products that you clean your office, but the key thing is to clean regularly and clean, and wash your hands. We would recommend that you use PPE when you're cleaning, remove it when you're done, wash your hands, and then let things air out in a room where there's been a patient who you think has COVID-19, but the cleaning process is the most important process for cleaning the fomites that may be on the surfaces. To protect your patients, there are many different links, and trying to stay up to date is difficult. And many of the links are very helpful, in particular from the CDC, for your patients and families to look at. Our American Academy of Pediatrics, we're trying to have as many outward-facing pieces of information for parents and families. Thinking about strategies to keep patients who do not need to come to the office away from coming to the practice. Your telephone system is important. Messages for when to seek care at the facility, where to seek emergency care, utilizing telephone triage, following up patients by telephone, using telemedicine as often as you can, and actually other self-assessment tools for patients and families to help them decide when should they seek care and how to go about accessing that care. There are COVID-19 resources on the CDC website for healthcare professionals. They usually put on the very front page, a note saying these are the things that were updated from the last time it was updated. The World Health Organization has some nice information about coronavirus. Our American Academy of Pediatrics homepage, as well as the Red Book Online, have information about COVID-19, healthychildren.org, and AAP News. We're trying to keep updated with the most up-to-date data as much as possible. I would like to offer and thank you for the time for listening to this webinar. And if you have questions about coronavirus disease 2019, COVID-19, we'd like to offer for you to email covid19@aap.org to get more information. Thank you for taking your time from this busy respiratory season and in the face of an unprecedented experience that we're going through with the COVID-19 pandemic. And thank you for what you do every day for taking care of our children and their families.